Palliative Care Series, Advanced Heart Failure, and Palliative Care. Heart failure is rising worldwide. Millions live with congestive heart failure, with projections reaching 8 million in the U.S. by 2030. Symptoms are common and costly. Palliative care improves quality of life by addressing physical, emotional, social, and spiritual suffering alongside treatment. Palliative care can begin at any stage of serious illness, while hospice focuses on the last months of life when comfort becomes the priority. Primary palliative care includes symptom management, advanced directives, and risk-benefit discussions. Secondary palliative care supports advanced disease, NYHA for symptoms, major interventions, and LVAD discussions. Heart failure affects more than the heart. Fatigue, breathlessness, pain, anxiety, insomnia, nausea, itching, swelling, and mobility limitations are common. Pain may come from edema, arthritis, or neuropathy. Opioids can help pain and dyspnea, while diuretics reduce fluid overload. When oral diuretics stop working, higher doses, IV or subcutaneous routes, or combination therapy may help. Inotropes may relieve symptoms but carry arrhythmia risk. Pacemakers, ICDs, and LVADs prolong life. Device decisions should trigger goals of care discussions. Newer LVADs significantly improve survival. Modern devices show about 58% survival at 5 years, nearly double older devices. In younger patients, survival with devices like HeartMate 3 approaches heart transplant outcomes. Most patients improve dramatically, often moving from severe symptoms to much better function and quality of life, with fewer hospitalizations. However, complications remain possible, including bleeding, infection, right heart failure, and readmissions. Outcomes are worse with poor nutrition, kidney dysfunction, right heart failure, or care in less experienced centers. LVADs also require intensive daily care and strong caregiver support, making social stability an important part of patient selection. LVADs improve survival and quality of life, but require major medical and caregiving commitment. Advanced care planning clarifies values, identifies a surrogate, and documents preferences. Referral triggers include recurrent hospitalizations, functional decline, increasing medications, device decisions, or starting inotropes. Hospice may be appropriate when prognosis is limited or patients choose comfort-focused care. Enrollment is flexible. PALHF and SWAPHF show improvements in quality of life, mood, spiritual well-being, and advanced directive completion. ICDs prevent sudden death, but shocks near end of life can be painful and distressing. Turning off shock therapy does not cause death, requires order, device team, magnet if urgent, and documentation. LVAD is a life pathway decision with benefits and risks including stroke, infection, and caregiver burden. LVAD requires palliative consultation and discussions about continuation and deactivation. After LVAD deactivation at the end of life, survival can vary, from minutes to several days. This unpredictability is important to explain to families. Some patients die quickly, while others live longer than expected. Preparing families for this range helps reduce fear, confusion, and distress. Time after LVAD deactivation is unpredictable. Inotropes improve symptoms but may increase mortality risk and signal trajectory shift. Inotropes carry an increased risk of dysrhythmic death. Starting inotropes often marks a transition toward trajectory management. Heart failure follows a fluctuating trajectory with sudden death risk. Uncertainty should prompt earlier conversations. Opioids reduce air hunger and improve comfort in advanced heart failure. Low doses are safe when carefully titrated and treat breathlessness, not just pain. Key takeaways: heart failure is common, progressive, and unpredictable. Patients often live with high symptom burden for years. Palliative care is not hospice. It can begin early and should run alongside disease-directed treatment. Symptoms drive suffering. Breathlessness, fatigue, depression, pain, and insomnia are major targets for palliative care. Technology changes decisions. Devices, inotropes, and advanced therapies should always trigger goals of care conversations. ICD shocks at end of life are common and preventable. Deactivation is a comfort-focused decision, not euthanasia. Unlike ICDs, pacemakers rarely cause distress at end of life. They typically continue silently and do not deliver shocks. LVAD improves survival and quality of life, but requires major commitment and ongoing reassessment of goals. Starting inotropes often signals a trajectory shift towards supportive and anticipatory care. Prognosis in heart failure is uncertain. That uncertainty is a reason to talk earlier, not later. Advanced care planning reduces crisis decisions and helps families feel prepared. Hospice is flexible and underused in heart failure.